ahead and spend just about a minute giving everybody an introduction to Dr. Adnan Qureshi, who's joining us today from the University of Missouri. We're very fortunate to have Dr. Qureshi come talk to us today. He's extremely prolific author of over 750 publications, internationally renowned expert in neurology, and many other medically related topics. So we're very lucky that he's here to speak to us today about the most recent cutting-edge advances in the endovascular treatment of acute ischemic stroke. This is something that we here have a lot of experience dealing with, as the stroke volume has dramatically increased over the past several years. And I'm sure everyone has noticed how it's a rapidly evolving field. So it's in our best interest that we also keep up to date on exactly how these patients are being treated. So no further delay.
Well, thank you so much for such a kind invitation, Samir. I think that I did want to mention that it's a real honor to be here. Also, I have a great honor to actually present in front of one of our mentors from medical school, Dr. Feroz Mahmood. So definitely very, very pleased to be here today. So I'm actually going to talk about the advances in endovascular treatment for acute ischemic stroke. And before we go further, I actually want to show a video because I want to actually illustrate what the procedure is before we start talking about the indication, I guess the value of the procedure and how to incorporate in routine day practice. We can cut the music. So essentially So I just want to show a real patient and a real procedure to familiarize everybody with what the procedure looks like. So this is, as you can recognize, acute stroke patient. You can notice the right gaze preference, no recognition of visual stimuli on the left side. And you can also appreciate the weakness of the face on the left side. Here you can actually see a difference in the strength, a clear difference in the strength on the left hand. And also a dense hemisensory loss as well. And then you can also appreciate the weakness in the legs as well. So you can see the left lower extremity actually is clearly weaker than the right. So it appears like a classic right middle cerebral artery syndrome. And that essentially takes us to the procedure itself. So the patient is actually taken to the angiographic suite. And essentially, you're all familiar with the coronary catheterization procedure, the cerebral procedure, but essentially the procedure starts with the femoral axis, and then essentially a catheter is advanced through the femoral axis through the arch of aorta into the supraortic vessel. So here the catheter is being advanced into the right internal carotid artery. So once these catheters are in what we call as a primary vessel, which will be the right internal carotid artery, you can actually see an injection of a contrast. And here you may be able to appreciate that one of the branches, so you're looking at it head on, one of the branches actually is missing from the middle cerebral artery. So now the basis of the thrombectomy procedure is simple. You have a catheter that's already in the internal carotid artery. And through that catheter, we advance a smaller catheter. And this smaller catheter is actually what we call as a microcatheter to denote a smaller size that allows it to go through within a catheter. And you can see this microcatheter being advanced through this guide catheter. And this is all being filmed in real time. So you can actually also appreciate how quick the procedure has to be done. And then the microcatheter actually has a small microwire, and the microwire allows to direct the microcatheter in the direction that it needs to go. So here you can actually see the micro wire, and to give you a sense of how small these wires are, they are a fraction of an inch. And here you can actually see the micro wire actually coming and moving in the internal carotid artery. And now we're looking at a side view, and you can actually appreciate the catheter and the micro wire actually moving in the internal carotid artery. And our target really is to get to the middle cerebral artery where the occlusion is. And here you can appreciate the micro wire actually going right through the occlusion. And then essentially the microcatheter is actually advanced over the micro wire and goes past the occlusion. And this has been the basis of thrombolytic therapy since the 1980s. And essentially we used to use these microcatheters just to inject thrombolytics. But over the last 25 years, I think there's increasing recognition that perhaps the greater value is what we call as mechanical disruption or mechanical thrombectomy of the thrombus. And now we have special devices. So you can see a special device that's actually being introduced through the microcatheter. And this device is it's like a stent that's connected to a wire. So obviously the device is introduced in a compressed manner. And once the device is advanced through the microcatheter, you will actually appreciate it in the imaging that the device comes all the way to the distal end of the microcatheter, which you remember is actually past the occlusion in the middle cerebral artery. And here you will appreciate the radiopaque markers identifying the device actually coming through the microcatheter. And once the device reaches the end of the microcatheter is simply withdrawn. And the device, by virtue of its biomechanical properties, just expands right around the thrombus. So essentially what you have is a stent that's embedded in the thrombus, but this is not a classic stent because it's still attached to a micro wire that can allow it to be retrieved. So here you can see the retrieval process and the deployment of the stent retriever. It's called stent retriever because of this, because of the property of its ability to be retrieved. And you may be able to appreciate the expansion right around the thrombus. So here is again. So now a large syringe is attached to the guide catheter to provide concurrent suction. And the purpose of the suction is that when you're retrieving the thrombus, to make sure no fragments of the thrombus actually dislodge and go back into the intracranial circulation. So here you can actually see the retrieval process, and the stent is actually being retrieved in an expanded manner. So it actually has entangled the thrombus with it. So here you can actually see the retriever coming through. And then it's very common that we are actually seeing thrombus that comes right with it. But here you can actually see it under fluoroscopy, how the retriever is being retrieved. So you can see the retriever being retrieved in an expanded manner, and the thrombus, which actually is not radiopaque, so it cannot be visualized. And here is the thrombus that was actually retrieved from the intracranial circulation. And now there's another injection, and there is still a fragment of the thrombus. So you can still see in an anterior posterior projection, there's still a fragment left there. So we are actually going back again, repeating the same procedure. So again, you can still appreciate the microcatheter and the microwire, the same paradigm. The guide catheter still remains in the internal carotid artery. So still have the platform to introduce devices without actually making the whole process from the femoral artery onwards. So once again, a repetition of what we had done earlier, but this time the fragment is a little more proximal. So last time it was in a branch of the middle cerebral artery. This time is actually right at the origin of the middle cerebral artery. So here you will be actually appreciate the microwire leading the way, and the microcatheter actually being advanced over the microwire. So here you can appreciate the thrombus. And now you can see the microwire coming and going right through the thrombus. And it's actually been interesting that it's very relatively easy to get past the thrombus. It's very rare that we actually have a difficulty getting through the thrombus. And I think that's probably one of the advantages that's opposed to acute myocardial infarction. We are predominantly dealing with embolic material. So the underlying vessel doesn't have a lot of atherosclerotic plaque. So it is really an embolic material that either has come from the cardiac source or perhaps from the arch of aorta. So here you can see the microcatheter going past the thrombus. And again, the microwire is removed, leaving the microcatheter in position. And this microcatheter can be used to instill thrombolytics, but more importantly, deploy devices that can retrieve the thrombus. And again, the retriever is being introduced. So the retriever again is in a compressed manner, and that's introduced right through the microcatheter. So now the retriever is being pushed through the wire that is attached to it. And the same process, the retriever will be actually deployed across the thrombus. Here you can appreciate the retriever, the radiopaque markers of the retriever identifying the retriever as it's making its way through the microcatheter. So again, the retriever is just going to be deployed by actually retraction of the microcatheter. And the retrievers actually are made of nitinol, so they do have a self-expanding property. So here now you can see the microcatheter being pulled back while the retriever is in position. And you can see the retriever starting to expand. Sometimes the retrieval process is a little bit painful for the patient, particularly when they're awake, because as the retriever actually expands, it does abut to the surrounding vessel wall. So here you can see the retriever in position right across the thrombus. And now again, this concurrent process of suctioning and retrieval. And it's interesting that how suction has actually emerged as an important tool in this whole mechanical process. And here you can see the microcatheter and the retriever being removed concurrently. And obviously the retriever is still expanded and hopefully has a fragment of the thrombus within itself. So here you can see the retrieval process. And here you can see the image, all the blood vessels are completely open, all branches of the middle cerebral artery are completely open. So essentially, angiographic recanalization has been achieved using this procedure, and in a very rapid manner, because as I said, this is all being filmed in real time. But more important is how is the patient doing. And you can actually notice that immediately after the procedure, patient has regained the strength in the left upper extremity, the facial paresis and the visual defects is no more. You can't even appreciate which arm was actually affected after the procedure. And in fact, patient is able to actually perform fine coordinated movements with the left upper extremity. So these procedures can be very effective. But then the question becomes is, what is the scientific evidence? I mean, obviously, one procedure with success doesn't mean that it should be applicable to a broader population. So I want to actually go through some of the science that has evolved in the last 25 years. I'm going to talk a little bit about technology and then actually talk about the scientific evidence, what are the current guidelines, and then, what are the protocols that are being used and what is the future direction as we go forward. So the technology interestingly has evolved. So basically we have thrombectomy devices and thrombectomy and retriever devices. The thrombectomy devices, the goal is just to fragment the thrombus and then have the thrombolytics dissolve the fragments. While the retriever, the goal is actually to ensnare the thrombus and remove it from the intravascular compartment. And the initial devices that we used in the 90s were more like some specialized wire that looked like a corkscrew, maybe the angioplastic balloons we had been using for intracranial atherosclerosis. But now we have more specialized devices. So we mentioned about this retriever, which is like a stent, an expandable stent attached to a wire. Now we have specialized suction catheter that can go all the way where the thrombus is. And a negative aspiration can actually take the thrombus out of the intravascular compartment. Now, technology is always a little tricky. Meaning you have technology, but most importantly, it should do something beneficial. So fortunately, when it comes down to endovascular treatment, the technology, so there are trials that have compared the previous technology to the new technology. So looking at basically the Mercy retriever was the corkscrew, which was the oldest design of retrievers we had, and comparing it to the new generation, which is the stent retrievers. And you can actually notice that in all the trials, the recanalization rate, which is the ability to open an occluded blood vessel, is clearly improved. So it's more effective to open occluded blood vessels with the new generation devices as compared to the old generation devices. But more importantly, what does it mean for the patient? I mean, are we seeing a better outcome for the patient or not? And we actually have this scale called a modified Rankin scale. And that is actually a scale that goes from 0 to 6. 6 is death, 0 means no deficits. And 1 means mild symptoms, 2 means minimal or no disability. And that is the goal of all acute stroke treatments, to achieve a modified Rankin scale of 0 to 2 at 3 months. And you can actually appreciate that with the new generation devices, you are actually seeing a greater rate of what we call as functional independence after treatment as compared to the old generation devices. So clearly we are seeing benefit in terms of patient outcome. And now, as I mentioned, that people have said, well, why don't we just use primary suction instead of using a stent retriever? And essentially, even though I was never a believer in primary suction, but if you look at the trials, one has to admit that primary suction appears to be almost as effective as a stent retriever. So these new catheters that can go all the way where the thrombus is, you can actually have the same result with suction thrombectomy. And the clinical outcomes are also similar. So I think now you have a choice: either you use the next generation of stent retriever or perhaps even a primary suction catheter. So that's where we are. I think we know that stent retrievers are more superior to the original retrievers, and now primary suction is as good as stent retriever. So what is the scientific evidence now? And fortunately, when we did this meta-analysis, and that was in 2016, there were already 15 trials that had been completed that were comparing best medical treatment, which actually could include giving intravenous thrombolysis to actually mechanical thrombectomy or endovascular treatment. And most of the trials actually are focused in the 6 to 8 hour range. So really taking patients who come in between 6 and 8 hours after symptom onset. And instead of going over all these trials individually, we can actually do a meta-analysis. So we can actually pool the results of all of these trials to see what the combined effect is. And if you look at the ability to achieve a modified Rankin scale 0 to 2, again 0 being no symptoms and 2 being slight disability, so really a very desirable outcome, also known as functional independence. The odds are actually significantly higher with mechanical thrombectomy as compared to best medical treatment, which does include intravenous thrombolysis. The odds are 1.8 and a confidence interval between 1.4 to 2. So highly significant benefit of endovascular treatment. And you can actually play around with the endpoints. You can actually take an excellent outcome as an endpoint, again, the same result. It doesn't change survival. And again, survival has never been a primary endpoint in any acute ischemic stroke trial because disability seems to be the major endpoint in these trials. So almost 80% higher odds of achieving functional independence with mechanical thrombectomy or endovascular treatment. And it certainly did not matter if you got IVTP or did not get IVTP. So it's not that intravenous thrombolysis patients benefit less. In fact, the evidence is the patients that actually get intravenous thrombolysis even appear to benefit more with subsequent endovascular treatment. So essentially, whether a patient gets intravenous thrombolysis or not, the use of endovascular treatment and the benefit appears to be independent of the initial use of intravenous thrombolysis. So based on that, in 2015, the American Heart Association actually recommended mechanical thrombectomy or endovascular treatment for occlusions that actually are in the middle cerebral artery or the intracranial internal carotid artery, because all the trials included these patients. Now, whether there is a benefit for more distal branches of the middle cerebral artery, probably there is, but the trials actually included a much smaller proportion. So now it's interesting that we have this evidence, but it really is coming from a selected segment of intracranial circulation. Granted that 50% of the strokes actually involve occlusion of the middle cerebral artery or the intracranial internal carotid artery. But there are occlusions in other blood vessels. And then what shall we do about that? And currently, all these patients with occlusion and other arterial circulation will also get endovascular treatment at all other centers. It is important to know that the trials actually did not include these patients. And perhaps the only difference is that patients who have occlusion of the cervical internal carotid artery or the basilar artery have a larger underlying atherosclerotic burden. So maybe there's a greater role for angioplasty and stent placement that you see with acute myocardial infarction than what we saw in the trial that involved middle cerebral artery and internal carotid artery. There is actually a trial that just got completed recruitment, just focusing on basilar artery. I was on the steering committee, but I don't know the results yet, so we should be finding the results. It is comparing endovascular treatment with best medical treatment within a 12-hour window for basilar artery occlusion. Now, the other thing is a time window, and it appears that the guidelines said that if the treatment can be initiated within 6 hours of symptom onset, then it should be indicated. And the reason is that obviously most trials are focused on patients that had come within 6 to 8 hours of symptom onset. So that's where the evidence is coming from. So the guidelines have to be based on the evidence. But people have been debating almost for 25 years that maybe there is a group of patients who even after 6 hours have salvageable brain. The challenge always had been how to identify the salvageable brain, what parameters to use to define who has salvageable brain and should actually get endovascular treatment after 6 hours of symptom onset. So the couple of recent trials that actually looked at how to identify that. So essentially using advanced imaging, so not the plain CT scan, but actually an advanced CT scan that allows you to measure perfusion and various parameters of perfusion by the distribution of contrast in addition to a plain CT scan. And based on various parameters of perfusion, you can actually identify a surrogate for what is salvageable tissue. So using that advanced imaging, if you select patient between 6 and 24 hours and actually randomizing them to mechanical thrombectomy, or best medical treatment, you can see that there is an advantage of mechanical thrombectomy. The functional independence rate is substantially higher as compared to actually doing nothing for these patients. So no other treatment, but whatever we call as best medical treatment, it's a dramatic difference. It's 48% versus 13%. So even patients who come after 6 hours, there seems to be a role for endovascular treatment as long as these patients are carefully selected. And similarly, another trial looking at patients between 6 and 16 hours after symptom onset, again, actually using infarct size, which is really derived from this advanced imaging, which is CT perfusion, and selecting these patients and looking at, again, functional independence. And once again, you see a dramatic difference. The functional independence rate is 45% as compared to 17% if no thrombectomy is performed. And these rates actually seem more dramatic than the rates that we saw when this procedure will be performed between 6 and 8 hours after symptom onset. Because at that time, you at least have intravenous TPA or intravenous thrombolysis. Anytime after 6 hours, there is no other option. So essentially, it's really mechanical thrombectomy versus no treatment. But I think that before we assume the importance of mechanical thrombectomy after 6 hours of symptom onset, we also have to understand that this question was not a new question. People have been trying that even in the 90s. The only thing that's different is that previously we used to select patients based on individual judgment, and there is considerable variation in between individuals when they look at these images. Now we have automated softwares that give an automated assessment and gives an automated value, a quantitative automated value on what is salvageable tissue. So for example, it does tell you that what is the tissue that actually has irreversible damage based on the perfusion pattern, and what is the tissue that actually has salvageable tissue based on the perfusion pattern. So you can actually do what we call as a mismatch, salvageable tissue versus irreversibly damaged tissue. And obviously, if there's more salvageable tissue, then the patient actually be a candidate for endovascular treatment. So I think that we just shouldn't forget that what has brought us to the place where we can actually do thrombectomies between 6 and 24 hours is the value of advanced imaging, automated quantitative advanced imaging. So we have this evidence now. The question is, what do the guidelines say now? So in 2013, the guidelines actually were very restricted and only were focusing on intra-arterial fibrinolysis, so basically intra-arterial administration of thrombolytics for patients who have an occlusion of a middle cerebral artery. And it was actually class 1 evidence, but it was still level of evidence was considered B. So it was not a strong evidence. All the emphasis was really based on giving intravenous thrombolysis, which used to be Activase. And all the focus was to call that as class 1 level of evidence A evidence. So after these thrombectomy trials in 2015, the guidelines had to be updated. Usually the guidelines were being updated every 4 years, but a special exception was made and it was updated in 2015. And it actually said that endovascular treatment is indicated with a stent retrieval, class 1 evidence, level of evidence A. And important thing was that even patients who had received thrombolysis In fact, the guidelines were saying everybody should get thrombolysis intravenously if they're a candidate. So it doesn't matter whether they're a candidate or not for mechanical thrombectomy. And then essentially it was emphasizing that the occlusion had to be in the internal carotid artery or the middle cerebral artery. The deficits had to be 6 or greater. So the NIH stroke scale, I'm sure you see it every day when stroke patients are being evaluated. It is a scale got to go from 0, which means no deficit, to 42, which means the worst possible deficits. So 6 or more means that there is actually significant deficits on the neurological exam. And again, the treatment had to be initiated within 6 hours of symptom onset. And then there is this aspect score, which something you may actually see mentioned in the chart. This is a score that's based on a plain CT scan and quantify the early ischemic changes that can be identified on the plain CT scan. Now, in 2018, the guidelines had to be updated again. So again, there's this rapid updating of guidelines that has never been preceded before. And this time, essentially, mechanical thrombectomy was indicated in patients who actually are within 6 and 16 hours, and it was recommended. And even if they were in the 6 to 24 hours, as long as they met the criteria, the imaging criteria that we had talked about earlier, it was considered reasonable. So you see how these guidelines are evolving within a period of 4 years, a very rapid transformation in acute stroke treatment paradigm based on these rapidly coming or rapidly emerging clinical trials. But again, guidelines are guidelines, and a lot of times it's hard to incorporate. How do you manage the next patient that comes to your emergency department? So that's why we have to transform to protocols. This was actually a protocol that we put in there, and that was in 2011, which basically was patients who came in within 4.5 hours of symptom onset. If intravenous thrombolysis was indicated, they should get intravenous thrombolysis. And based on the severity of neurological deficits, if patients who had an NIH stroke scale of 10 or greater, so again, the scale goes from 0 to 42, 0 being no deficits, 42 being pretty severe, the worst possible deficit, and 10 or greater are pretty severe neurological deficits. Because patients who had large deficits were usually the patients who had an occlusion of a major intracranial artery, those patients would actually get endovascular treatment. And essentially in those days, what it meant was catheter-based treatment with some injection of intraarterial thrombolysis. If they presented between 3 and 6 hours after symptom onset, intravenous thrombolysis was not an option. They can go straight for endovascular treatment. And after 6 hours, there was sporadic use of endovascular treatment. And again, using MRI scans and CT scans, advanced CT scan, but a lot of deviation or variance in how these patients should be selected, what patients had salvageable tissue and who did not. But there was still a sporadic use of endovascular treatment even in this time window. In 2016, the protocol had to be updated. And again, intravenous thrombolysis still retains its place, but the clinical exam loses its place to CT angiograms. And CT angiograms are done today everywhere as part of the initial imaging or neuroimaging for acute ischemic stroke. And if the CT angiogram actually shows an occlusion of a major intracranial artery, then the patient can actually go to endovascular treatment. And again, for the 3 to 6 hours, CT angiogram again being used to select these patients. And for greater than 6 hours, again, there is a group of patients that actually have salvageable brain, but it's a small group of patients, so it has to be carefully selected. And in those days, it was looking at collateral patterns with CT angiogram and just even looking at plain CT scan to exclude patients who had early ischemic changes. And contrary to the popular beliefs, the CT scan that are actually acquired in the hyperacute period seemed to have more information than we had initially anticipated. But endovascular treatment itself was being standardized as stent retrievers were being introduced. And there was actually more emphasis on doing these procedures quickly to make sure the procedure was started quickly and ended quickly to get the maximum benefit. And in 2018, the guidelines, at least the one for patients that came in after 6 hours, have to be updated. And again, quantitative assessment to determine what was salvageable or irreversible tissue and what was potentially salvageable tissue, and then selecting these patients for endovascular treatment. Now, one thing that actually has disappeared from endovascular treatment is the use of concurrent intra-arterial administration of thrombolytics. It seems that it's all based on devices now, and very rarely intra-arterial thrombolytics are administered during this procedure. So this is actually the most current paradigm. You can actually see how these paradigms have evolved over a period of 7 years, and with more emphasis on using advanced imaging, CT angiograms to select these patients, actually using special protocols for the procedure itself, and evolving or actually automated assessment, quantitative automated assessment to determine salvageable tissue in patients who come after 6 hours. So that is actually where we stand in what the protocols are. Where do we go from here? So this is actually almost like a chronological order of how we have evolved in patients who actually used to come in the acute period of ischemic stroke. In the period one, between 1995 to 2001, it was all about intravenous thrombolysis. Patients who came in within 3 hours should get intravenous thrombolysis. In period two, we had intravenous thrombolysis, but people realized that intravenous thrombolysis, there was still a pretty high rate of death and disability. So there was a role of mechanical thrombectomy in these patients. So after getting intravenous thrombolysis, many centers would actually take them for mechanical thrombectomy or endovascular treatment, almost like some people used to call it the combined approach, some people call it the bridging approach. But whatever that approach was, there was additional mechanical thrombectomy done after giving intravenous thrombolysis. And essentially, we did some studies in that time too. There was a big concern that whether it was even safe to do mechanical thrombectomy after somebody had received intravenous thrombolysis. But now I think there's pretty unanimous data or a pretty large body of data that definitely is safe. And then in period three, between 2009 and 2015, you had intravenous thrombolysis that actually the window was expanded to 4.5 hours. So because of a recent trial, they actually expanded the window. So not within 3 hours, but now within 4.5 hours. And then there was evidence that mechanical thrombectomy clearly provided additional benefit. And it's actually just abbreviated as MT, but it means mechanical thrombectomy. And there's a widespread adoption that even if patients get intravenous thrombolysis, they should actually get mechanical thrombectomy. And now we are in the period four, we have this challenge. I mean, where mechanical thrombectomy is providing the major recanalization. So people are starting to question whether there's even any role of intravenous thrombolysis. Why not just do mechanical thrombectomy alone that's done in acute myocardial infarction? Why do we even need to give intravenous thrombolysis before actually going for mechanical thrombectomy? And there is some data to suggest equivalence, but somehow it has not really, there's limited or no adoption. But there's no center in the United States that would not give intravenous thrombolysis to somebody who actually qualifies for intravenous thrombolysis. So now we are in the period five, where we definitely need some definitive evidence where mechanical thrombectomy alone can provide the same level of benefit as a combination of intravenous thrombolysis, mechanical thrombectomy, and our practices should be modified. And basically, the big question now has become is whether there's any role of intravenous thrombolysis in this particular protocol sequence when we actually are heavily relying on mechanical thrombectomy or endovascular treatment to provide the therapeutic benefit. And there actually have been trials, there are 4 trials that have been completed all outside the United States, and that actually have shown equivalence. So you can look at this meta-analysis, and you can actually see modified Rankin scale of 0 to 2 or functional independence. There is no difference whether you get intravenous thrombolysis and then get mechanical thrombectomy, or you actually proceed straight to mechanical thrombectomy when you're presenting within 4.5 hours after symptom onset. So there is evidence of equivalence, but not from United States. And then essentially there was actually another trial, a phase 2 trial that we completed, the ASTO 2 trial, ASTO 1 actually, where actually it was a single arm study looking to reject the futility hypothesis and actually successfully rejecting the futility hypothesis that there should actually mechanical thrombectomy alone can provide the same level of benefit used to historical controls where get intravenous thrombolysis followed by mechanical thrombectomy. But the reality is that all the current guidelines still advocate intravenous thrombolysis before mechanical thrombectomy. And it's unanimous across the board. So what that means is that in the future, there would have to be a large clinical trial that would have to compare intravenous thrombolysis and mechanical thrombectomy alone, and most likely in the United States before the guidelines actually will be changed. So I want to conclude here with the following statements. I think that recent clinical trials have demonstrated a significant benefit of endovascular treatment in patients with acute ischemic stroke. But I think it's also important to emphasize the importance of unique patient selection criteria and treatment paradigms. I think large magnitude benefits can be expected with the implementation of parameter optimized endovascular treatment. And I use this first parameter optimized endovascular treatment. So endovascular treatment, when the parameters are not optimized, will not provide the benefit. So what that means is that it's a rapid time to treatment. As soon as the patient comes, a rapid triage and rapid time to treatment, endovascular treatment. Fast procedure time, so really completing the procedure within 60 minutes of starting the procedure. And achieving a high rate of recanalization, high rate of opening occluded blood vessels. And even then, if we can achieve these parameters, only then we can see a large magnitude benefit even in patients who are actually candidates for intravenous thrombolysis. And large magnitude benefits can also be expected with the implementation of selection based on quantitative assessment of penumbra, which is really salvageable tissue, and infarct, which is insalvageable tissue, and determining the magnitude of salvageable tissue in patients with ischemic stroke who come between 6 and 24 hours after ischemic stroke. Well, thank you. So I just wanted to leave some time for questions and discussion. We have volume. We have to put the volume up.
Do we have time for some questions or not? So now, how you? Great talk, by the way. Quick question about the initial part of it. As anesthesiologists, we are often called in to do these cases like at a head drops notice. And we're supposed to do them with absolute no anesthetic at all. Are there anything to make it simple for us, or just stand over there just to see if something bad happens, or is you can do something to control the patient or something like that? What affects your business?
So I think this is an excellent question. I mean, there has been, so if you look at clinical studies, patients who actually get mechanical intubation and mechanical ventilation, the outcomes have, the death and death distributed rates are actually higher in those patients as compared to patients in which the procedure is actually performed under conscious sedation. Now, there's a little trick. Obviously, the patients who are more severe deficits are likely to get anesthesia. Likely to get intubation and mechanical ventilation. But even people have tried to balance with it using propensity adjustment, multivariate analysis. There seems to be that element that somehow intubation and mechanical ventilation actually appears to increase the chance of death and disability in patients getting endovascular treatment. And two hypotheses have been put forward. One is that there is this transient hypotension, a relative hypotension, which you see with anesthetic agents. And second, actually, is interesting that people have said that there is this hypocapnia. So there is this hypocapnia because obviously you're trying to, before intubation, and after intubation, and seemed like hypocapnia is actually bad for brain ischemia. So essentially, that's what our understanding is. Now, there are 3 randomized clinical trials that have been done that have actually compared the same kind of patients to conscious sedation and actually mechanical ventilation and intubation or general anesthesia. And the rates of death and disability are essentially the same. So it appears that when anesthesia is actually done under controlled circumstances, the outcomes, or in a comparable group of patients, the outcomes are pretty similar. Now, the issue is that, at our institute, what we used to do was we used to make a determination whether to use anesthesia or not based on the clinical severity of the deficits. Now, what has actually changed is that it created a very sporadic pattern. So I think that, as I mentioned, that for our anesthesia colleagues, a lot of time it just became like at a drop of the head, they're just being notified, look, we need anesthesia. And a lot of time it was during the procedure. So the procedure has started, and then in the middle of the procedure, it becomes clear that this patient cannot continue without actually being intubated, mechanically ventilated, and having general anesthesia. So obviously that even puts a shorter timeline on the requirement of the help. So I think in our institute now, it's all people are getting general anesthesia. Anesthesia team is already notified as soon as the decision for mechanical thrombectomy is made. So that's the practice at our institute. I know there's a wide variety of practices across the country. But that's what we know about the use of anesthesia as part of mechanical thrombectomy. We have another question here. So patients who are outside the window for TPA, but mechanical intervention may help. But in many places, it's not being considered. So this is actually an interesting question. And many years ago, we actually did what we called the Buffalo and Erie County stroke study, and that was done in the 90s. And it was actually just looking at all the hospitals in that region and looking at all the acute ischemic stroke patients that were actually presenting and at what time frame they were presenting between symptom onset to the hospital presentation. And, in those days, the classic reason, because IVTP was only being used in 1 to 2% of the patients at that time. The classic reason was patients don't come to the hospital in time. So that is why the use is very limited. But in our study, we found that 33% of the patients had presented to the hospital within 3 hours of symptom onset. And only like 5 to 10% of them were getting IVTPA. So there is actually a whole emphasis that went into the fact that, while we're emphasizing to get the patients to the hospital in time, we also have to be ready in the hospital when these patients arrive. And essentially the hospital triage systems have to be put in place. And this has always been a challenge in many hospitals where, a notification system has to be done. And, as the question correctly identifies that while the systems actually are so attuned to intravenous thrombolysis, so perhaps if the patient comes in within 4.5 hours, all that system will be activated. But if a patient does not come in that time frame, but still may be a candidate for mechanical thrombectomy, none of these systems are activated. And I think that just requires a lot of emphasis on somehow creating this triage system and having a greater level of awareness at the initial triage, perhaps at the EMS level and more at the emergency department level, that perhaps there's still a role between 6 and 24 hours after symptom onset. And these patients will still have a rapid triage, which means rapid neuroimaging, to make sure that we are not missing patients who actually may be potentially candidates for mechanical thrombectomy, even though they were not really in the intravenous thrombolysis window. So I want to actually ask a question from the audience. You provide a lot of support and care for this thrombectomy patients. What has your experience been with anesthetics? Have you noticed that additional steps are required to prevent hypotension? Are you actually using prophylactic vasopressors, or at least having them available during the anesthetic process? Is your preference been for gaseous anesthesia, or has it just been mainly, I guess, intravenous anesthetic agents?
I can answer that question for you, Dr. Qureshi. It's pretty interventionalist dependent over here. Some of the folks are pretty ardent supporters of virtually no anesthetic and solely blood pressure control unless the patient truly cannot tolerate it. But I'd say that most of the more recently trained physicians that are performing these procedures are far more open and often straight out request general anesthesia at the very beginning. So a lot of it just depends on the comfort level there. We tend to use again, a lot of our anesthetic choices are going to depend on the anesthetic condition as far as what agent we use. But often the simplest choice for us is volatile anesthetic down there.
We have,
and we're doing our best to follow, to stick to all of the blood pressure recommendations for pre-intervention, post-intervention. We have very open communication with our interventionalists about post-intervention, blood pressure parameters and how to modify them accordingly based on the TICI score and this and that.
This is actually an interesting trial that was completed in France, and it was actually looking at blood pressure after the thrombectomy. So, like we always have this concern of lowering blood pressure in the acute phase of ischemic stroke. But the hypothesis was that, once you've had the thrombectomy and there's reperfusion, maybe a lower blood pressure should be more beneficial. And the trial actually showed completely the inverse, that lowering blood pressure and maintaining it to a systolic blood pressure value of less than 140 millimeter of mercury was actually not beneficial as keeping it to just less than 180 millimeter of mercury after mechanical thrombectomy. So there is still probably some tissue that's a little bit more vulnerable to blood pressure reduction even after the perfusion had been established in mechanical thrombectomy. And then we have another question about antiplatelet treatment. And this is actually a very interesting question. And I will, because we actually were involved in some of the research around that. So, with thrombolysis, it's always been a question that, when you give thrombolytic, there is platelet aggregation or activation of platelet aggregation. When we used to do primate experiments and you were using retaplase, you could actually see the aggregation increase dramatically because we were measuring platelet aggregation. So the platelet aggregation is responsible for re-occlusion, which actually does happen in 10 to 15% of the patients that get mechanical thrombectomy. And re-occlusion is actually bad. It does clearly patients who have re-occlusion seem to have a higher rate of death and disability in clinical studies. So a concurrent administration of antiplatelet agent, so whether it's actually an oral antiplatelet agent to precede the procedure, or actually a intravenous glycoprotein 2B3 inhibitor during the procedure. And I think that, we actually did a FDA trial as well using abiximab, intravenous abiximab as a concurrent treatment to mechanical thrombectomy. And several others, and it continues to be used. And I think there is continues to be use of intravenous integrin or abiximab as part of this procedure in a sporadic manner. And this seems to be more of an institutional-based choice. I think that perhaps the greatest agreement right now is that if a patient gets angioplasty or stent placement, then these agents should be used. And perhaps a lesser agreement that whether there's re-occlusion during the procedure, then these agents should be used. And then it's interesting that many patients still get aspirin in the ambulance. It is actually surprising. The challenge there is that sometimes you can't tell the difference whether it's an ischemic stroke or an intracerebral hemorrhage. The chances obviously are this most like ischemic stroke, but there's always that chance that this may be an intracerebral hemorrhage. So that's why we try to discourage this practice till the imaging is done. And then actually, I think that right now, as I mentioned, that mainly the role of antiplatelet agents in the acute period is if angioplasty and stent is done. Otherwise, these agents are actually to be avoided in the first 24 hours, which is consistent with the American Heart Association guidelines.
Thanks for answering that question, Dr. Qureshi. Based on what you just said, that those medications would be delivered intraprocedurally? Is that typically done? Yeah, so is that in an awake patient or in a sleep patient, orogastric or nasogastric tube would be inserted and delivered via that? Is that how you guys are doing it there?
So, yes, so with the nasogastric tube, that's correct. But I think that if an angioplasty or a stent is placed, then we actually start intravenous infusion. So we would give an intravenous bolus and infusion right in the angiographic suite. So we will just use a glycoprotein 2b3 inhibitor.
Thanks for answering that question. We've seen an increase in the request from our interventionalists to place NG tubes intraoperatively, intraprocedurally, to deliver integralin and aspirin. It's been kind of up and down. Sometimes they just come in bursts, and they're requesting it very regularly. And as I mentioned, some of the proceduralists we opt for awake patients. So there's a fair number of considerations for us as far as placing an NG tube in an awake supine patient.
And
thanks for that insight. It's very helpful.
That actually another interesting question, that at least for clopidogrel, which we use a lot, there seems to be absorption actually altered if the patient is actually under general anesthesia. So that's another consideration for all of us, that if you're going to use a bolus of clopidogrel through a nasogastric tube during the procedure or immediately after the procedure, the absorption pattern may actually be more restricted. And I think on the chat box, there's a very excellent review that was identified by Dr. Boss as well about the use of general anesthesia as part of mechanical thrombectomy and endovascular procedure.
All right, Dr. Qureshi, thank you so much for joining us today. This is a really fantastic talk. I think we all learned a lot from what you were able to share with us today.
Well, thank you so much, Samir, for inviting me. It was actually a pleasure. And as I mentioned, it's a great pleasure to present in front of my mentor from medical school as well. So thank you very much.
Yeah, we're fond of photos as well.
Great. Thanks so much.